Thanks very much for inviting me to present our case, and I hope this is a case very interesting. The case is 70 years old. This is a VIP person and referred from the hospital because of non-STEMI on 17th of March this year. He has history of a PCR and in that hospital, and one stent was implanted in at obtuse marginal on March 11 last year. The risk factors was hypertension and hyperlipidemia. And when at the emergency department in our hospital, there's no chest pain, blood pressure was normal. The heart is 80 beats per minute, no sign of heart failure. And the laboratory finding was the abnormal CKMB was increased. It's like confirmed that it's a non-STEMI. Troponin is increased. And then the LDL cholesterol is 94, creatinine 1.2. And you can see here in the ECG that no Q wave, and then it's only ST present at the V4 and V6. The cardiography completely normal. That's global normal kinetic. This is the angiogram. You can see here that it's a very tight stenosis of the distal left main. Some lesion at the proximal LED. If you look here, there is clearly there is might be obtuse marginal or might be ramus here because it's very close to the LED, and significant stenosis of the ostial of the circumflex. And again, as you can see, this is a left dominant vessel. The circumflex is quite big here. If you look from the spider view, you agree with me that this is obtuse marginal, and then the ostial of the circumflex is really tight stenosis, and there is also significant stenosis at the ostial of the LEDs. This is really complex of the left mid. So because it's very difficult to wiring to go to LED or to go to the circumflex. So what we can do is actually just to ballooning of this ramus. And this is I do from the distal radial, transradial, distal right transradial with a slender technique using XP guiding catheter 3, 7 French. It's a very nice, even using a transradial, but feeling like femoral. It's in the future, of course. I do believe that distal right or left transradial become default access. And then I can easily now to go to the circumflex with the dual lumen catheter. And finally, I can cross to go to the LED. Then, because very tight ramus, I do with not with the regular balloon, I do with the Scorflex balloon 2.5, 15 millimeters, and then go to the LED also with the scoring balloon 2.5. It's not only just to pre-dilating for IVUS, but also to prevent to making avoid to side brains occlusion. So this is the IVUS. You can see this very diffuse disease from the distal of the LED. You can see, agree with me that sometimes you can see some fibrocalcified here, but sometimes very superficial of the fibrocalcified here. Yeah, this is close to the left mid. This is circumflex, and this green. You agree with me that this distal part of. Sorry, this is left mid now. So if you look here, that the MLA on the distal part of the LAD is around 4.3, and then the mid is 5, and the distal left mid is 4.3. But you appreciate with me that the diameter of the LAD is quite big, 4.24, and then left mid is 5. This is circumflex. Circumflex is quite big. And yeah, this is obtuse marginal, and then diffuse here. Okay. Yeah, this is LED, and this left mid. So the diameter of the circumflex is 4.5 here. The distal circumflex 3.75. So in summary, this is 70 years old patient with non-ischemic atrial function is good, left dominance with big artery, and then trifurcation, critical left main stenosis, Medina 1-1-1-1. So what would we do?
Dr. Hikichi, maybe
yes, thank you very much. I announced the Yamawaki Sensei. Okay, Yamawaki Sensei is one of the most famous doctor in Japan. He is in the Yokohama, Saiseikai Yokohama Tobe Hospital. And he works very hard and conducting the clinical route research. He is a core member of the next generation Japanese bifurcation club. Yamawaki Sensei.
Thank you very much for the opportunity to present my strategy in this particular difficult patients. So this patient is 70 years, relatively young, a little bit older. The patient and the hemodynamic is stable and complex trifurcation in angiogram. So when we look at the iris from the circumflex, from the circumflex, the iris indicate that there are the thrombus in the trifurcation, and 1 o'clock the bilateral artery wire is coming. That the orifice of bilateral is taken from the iris finding, and immediately after that the LD, this is the circumflex. This is a no bifurcation, and immediately after that, the LD wire is coming to the 1 o'clock. So my question is this a true trifurcation? In angiogram, it's a true trifurcation, but I was finding this is not true trifurcation. The bilateral artery is originated from a little bit circumflex side. So I want to perform the IVAS from the bilateral artery. So I want to check the plaque distribution and which part is originated from the bilateral LAD or the circumflex or true trifurcation. I want to check the IVAS from, but there are no data of the IVAS from the Munawar's procedures. So that I expect. So that when we look at the LAD IVAS, the orifice of the LAD, a little bit calcium exists at the counter side of the circumflex, superficial calcium, and we can see the thrombus formation in the trifurcation. So I think that I agree with Dr. Munawar that this is a very, very high risk of the side branch occlusion anatomy. In angiograms, the high angle in the LAD and the left domain, it is easy to be occurred in the carinative. And from IVAS finding, there are the calcium on the counter side of the circumflex and the thrombus. Thrombus is a plug is easy to move to the side branch. So the plug and the thrombus shift is easy to occur. So very, very high risk bifurcation. So the crossover is the risk of we lost the branches. So that we have to prepare. I would write the several strategy in the single stent technique, no kissing, that which actually should we perform the kissing. On the second is directive to stent in the carotid tap, the mini flash or DQ flash. And also the stented strategies that Professor Hikichi presented DCB and the DCA strategies. In Japan daily practice, we can use the directional directomy device and the combination of the two devices. We can sometimes treat the young patient for the stent-less strategy. But in this situation, Dr. Munawar inserted the 6 French surrender seats to this area. We don't like the additional 8 French guidance for patients. And if possible, to finish this the complex bifurcation without stenting. So, and also this is not elective, but the emergency patient, and I was finding the thrombus and the trifurcation. So that in Japanese daily practice, we cannot use the cangular the bolus to Y12 inhibitor. So that and we have the risk of the stent formation during the DCA. So that I don't want to perform the DCA in this situation. So quick strategy. So finally, my strategy is simple final single stenting and final kissing bone for the LAD and circumflex and tap, because the lateral is not so compromised because the orifice is a little bit to circumflex side, or if the lateral artery is occluded, it's easy to cross the wire compared to the very high, very angled circumflex. So that I will just leave the wire to the lateral artery only. So that I want to use the modified jet balloon technique for the circumflex. The original paper is published in 2006 in the European version, but my centered strategy for the modified jet balloon is a little bit it looks like the snuggle kissing, and the proximal marker is just the adjusted main vessel standing, and that look like the lower part figure. So my strategy is right here. So like I want to show you my strategy. My strategy is the provisional single stent, provisional tap strategy with modified jet balloon technique. I want to insert a 4 wire for the LAD D1, the limbs and the circumflex with using the W catheter. And I want to perform the very small balloon to this middle limbs hierarchical artery. And I perform the IBUS and decide the landing zone of the distal part of the stent. When we look at the IBUS, beyond the first diagonal, we can find a good position is the lumen. Lumen is around 3 millimeter or more. So I want to put a stent in the distal in the less than the 40% plus area in visual. So I want to stent here with modified jet balloon technique. The modified jet balloon technique, the original is a smaller size balloon, but I want to perform the little bit larger size, 2.5 millimeter round, and with the only protection for the diagonal artery and hierarchical. And the part with IBUS guidance, so the 4.5 or 4.8, according to the IBUS. And next, I use the W catheter on the wiring inserted to the circumflex as a near carina, and avoid the abdominal wiring, and check the IBUS on the appropriate wire insertion point. And after that, we want to perform the final kissing balloon technique to the LAD and circumflex. And so the checked angle. So if the diagonal and hierarchical is the less than the pin 3, the pin 0, pin 1, pin 2. And I want to perform the wiring and ballooning with very smaller balloon size. The achievement point of such the smaller size of the side branch is the pin 3. If the circumflex orifice is more than the 70% visual, or the pin less than the pin 2, the pin 0, pin 1, pin 2, or if the circumflex is a very big artery for patients, so in that situation, I want to perform the tap technique, additional stenting. This is my strategy. Thank you very much.
Thank you very much. Can you hear me well, and can you see my slides?
Yes. Okay.
So I will start as a summary, just to mention that it was non-STEMI with positive lab documentation, and by echo it was normokinetic. And I really respect very much the first part of the procedure, which was presented by Dr. Munawar, since I believe this was the most difficult part, to be honest at all, in my interpretation, since he really was able to wire all the vessels, which is, I think, in this complex anatomy, extremely difficult. And to do that, he had to wire intermediate branch first. And if I understood correctly, he already pre-dilated the lesion in the high lateral or intermediate branch or high obtuse marginal branch. So since it's within 3 millimeters from the ostium, according to current definitions, it could be considered also trifurcation, distal left main through Medina 1111 lesion, and scoroflex predilatation, permitted performance of IVUS. So we understood that there is diffuse disease in the distal part of the left main, in the proximal part of the LAD, as well as in the ostium of the circumflex. So if we mention what is written in the consensus documents from the European bifurcation clubs about treatment of left main trifurcation, so this is a summary of sentences that I made based on the article in which Dr. Burzota was the lead author. So there are no standardized techniques for the left main trifurcations. We also favor single stent strategy when feasible, because it's associated with a higher procedural success and lower rate of events at follow-up. And what we recommend is, of course, to have plan A and plan B, be ready to perform a bailout strategy if we have dissection or flow compromise. And during the provisional strategy, crossover is decided based on clinical and angiographic event, and we strongly recommend use of coronary imaging to guide the procedure and to optimize the result. If we just simply look at the angiographic appearance and trying to find the perfect technique, it's very difficult to state in advance whether we will have the same strategy for the upper and lower anatomy of this trifurcation. The lower one looks even more complex. And this is the final angiographic result, I think very acceptable in both cases. But if we look what was done, the first one was done by stenting all three arteries. And the second one, this nice result was able to be achieved just with single crossover stenting towards the LAD. So our decision making is based on careful analysis of the side branch size and importance, the perfusion territory, plaque distribution, extent of disease, of course, angulation, and we keep in mind the fractal law, and it's just modified compared to bifurcations with the coefficient of 0.577 instead of 0.678. And based on the caliber discrepancy, we try to plan the strategy. And of course, in my way, I just put very important for me angiographic appearance of predominant huge plaque amount distribution in front of the ostium of the circumflex. So we know that in general plaque is in the lateral walls in front of the ostium of the LAD and the ostium of the circ. And we also see that there is a diffuse disease in the not only in the ostium but also in the whole proximal part of the LAD. And we understood from the IVUS pullback in both arteries that we have also very huge plaque burden and partial calcification also inside the distal left main. So in my interpretation, I also vote for, in general, efforts to limit the amount of metal. And this is just the bench testing imaging from Francesco Burzota, showing how we use crossover technique and triple balloon inflation tracing or kissing in left main trifurcation. So after crossover stenting and proximal optimization, we exchange the wires, and then we start with separate balloon inflations, and then, as you may see in different colors, simultaneous tracing or inflation of all 3 balloons. To be able to perform this, we need at least 7 French guiding catheter and new low profile coronary balloons. And of course, after tracing, we need to finalize procedure with proximal edge balloon inflation. And this is the end result. However, in this case, I would do a relatively similar strategy, but because of plaque distribution in front of the ostium of the circ, my strategy would be a slender sheet, of course, 7 French inside, extra backup with 3 wires, so LAD, intermediate, and circ. IVUS imaging that was already done, and then pre-dilatation towards the circ with cutting or scoring because of the presence of calcium, but other adequately sized balloon. And then I will decide to do in provisional in the inverted fashion, stenting from the left main into the circ, which is a large vessel. We already understood that in this proximal part, circ is very big. And then optimization of the stent inside the left main with pot and kissing. My strategy for intermediate branch, which was already dilated, and we saw on the IVUS that ostium is not such a compromise, will be to keep it open. So just keep a wire inside. And because of most of the plaque distributed in the area of the lateral wall in front of the circ and not such high plaque burden in the LAD, I think that having jailed the wire protection in the LAD is quite enough. And in my practice in general, I don't use any kind of jailed balloon technique. We learned with time that we can always, in case of the occlusion, because of the fractal geometry, we can go with a small balloon on a jailed wire and recover flow in the artery and then repeat the procedure. So after tracing, because of dilation and diffuse disease in the LAD, I will not leave without stent the ostium of the LAD. So the last step of the procedure after tracing will be tap stenting with precise position in the ostium of the LAD, kissing because we already have balloons inside, and then final confirmation by IVUS and final proximal stent edge balloon inflation. Because of all these manipulations and multiple devices inside, we have very increased risk of a longitudinal stent deformation with the guiding catheter. So I think we should finish this complex procedure with, it's not really final pot, it's just balloon inflation at the proximal stent edge. And we try not to come even close to carina because of short metallic neocarina. If we come with balloon distally, we take a risk of shifting that metal towards the ostium of the LAD. So tap stenting, inverted provisional from LAD to the circ, balloon optimization, tracing, and then tap stenting in the LAD, and final proximal balloon inflation and imaging to confirm adequate optimal result. Thank you very much for your attention.
So Dr. Munawar case is really challenging, and I believe every operator will probably have different strategy in dealing with such complex case. So firstly, in the setting of acute coronary syndrome, I personally tend to avoid complex procedure. Secondly, I can't convince myself that a single stent strategy would give an optimal result, optimal long-term result in such complex anatomy. So having that reasons, upfront two-stent strategy using simpler technique would be my preferred approach. And after listening Dr. Hikichi's lecture, I'm quite comfortable to use high pressure culotte for this case and just keep it open for the intermediate branch, if necessary, use drug-coated balloon. Thank you.
Yeah, I believe there's definitely very clear end stage of complexity. There's really very complex trifurcation, bifurcation, a minimum. You need to perform perfect lesion pre-dilatation or preparation. And I think you saw, as Goran mentioned, this huge plaque burden is primarily in going from left main to circ to LCX, and definitely you have to manage this part as first lesion preparation step. And I could imagine in this case maybe even shockwave balloon will be option to make really progress if you stand from left main to the circ to achieve really perfect result. If we perform double stenting of distal left main, as you know, usually we have a problem with the circ ostium, and probably because we don't make perfect lesion preparation. So I think in this case, predilatation with 3.0 and C balloon will be option as first step, or 2.5. Then if the result will be not perfect, then definitely I would try to use here shockwave balloon from left main to circ. Of course, if you use shockwave balloon, that's a benefit. You can have some other wires in position. If you use orbital atherectomy or rotablator, so you can always only work with one wire. So, and then the next step will be definitely first to stand from left main to LCX, and then perform kissing with brachycoated balloon option to the marginal branch, kissing with LAD. Most probably LAD will be still not perfect, then I would go with Dickey culotte. This will be for me maybe better option to be 100% sure we cover the LAD ostium perfectly. And of course you have to use stents with really capacity to be to go up to 6 millimeters nearly. Thank you.
Yeah, okay. So this my comment is actually almost same like Professor Stankovic comments, except this patient has STEMI, yeah, so high thrombotic risk. So I think using the less metals or simpler procedure may be better. And this is a Trifurcation Medina 111 or Medina 111. I don't know, because the intermediate is like a small. Even Dr. Yamasaki said that might be the first brand of the circ. So I don't know, this is 1111 or 111. So the circ is larger than LED. So I consider the circ as a distal main branch, because the higher diameter compared to the LED. So, and also the circs are also very dominant vessels. And the angle to both circ to an LED is more than or around 90 from the left main. So I think it's also can be one of the consideration to choose which strategy can be implemented. And according to ABC main study, that the simple layered professional strategy should remain the default for distal left main stem bifurcation, because the result of both two studies is comparable and even fewer adverse events if using the professional stenting. But according to the DK Crash 5 study, that professional stenting for unprotected left main bifurcation was associated with a significantly increased rate of TLF and stent thrombosis over 3 years follow-up compared to DK Crash strategy. So DK Crash is preferable strategy for true bifurcation left main. And according to definition 2 study, the two stent technique is superior to professional approach in true complex bifurcation lesion. And in this study, the most of the two stent strategy is using the DK Crash technique. But and Brilakis also advise some cascade that to choose a bifurcation treatment strategy. The first, we need to consider the side branch need to be preserved or not. If no, just one PCI at the main vessels. But if there is a need to be preserved, we have to check the likelihood of side branch occlusion. If there is a low likelihood of side branch occlusion, we maybe implement the professional stent strategy. And if high, we plan to stent strategy. And in this case, I think because of Dr. Munawar has already prepared the lesion with the scoring balloon 2.5 at both branches, and both vessels very big. So I think the likelihood of side brain occlusion is quite low, even though we still have to be very careful on this. But if we consider it's high, we plan to stent strategy, considering the side brain angulation. If the side brain angulation is around 70 to 90, we consider the T-stent or TAP. And if side brain angulation is less than 70, decay crash, or maybe culottes. Yeah. So I think in this situation, the side brain is around 90 degrees. So T or TAP will be preferable compared to the decay crash. And this is a stepwise. I think I don't need to tell the details, but I think same like Professor Stankovic, I think, but the difference is, I think maybe I consider if I choose the professional standing strategies, I consider to do the kissing balloon using 3 balloons, but small balloons for the intermediate. And then using a big balloon to the proximal main branch. So we do a kiss pot with triple balloon. And then if we choose a systematic to stent strategy, I prefer to use a T or tap technique, considering the angle is very steep, almost 90 degrees with the same steps like option 1. But be careful to apply the final pot, especially if we choose the tap strategy, because it may change the stent at the ostium, especially if the protrusion of the side branch stent is too deep. So we have to be very careful on using the final pot in this strategy. This is just to remind the audience that if we do the recrossing at the proximal part, we will take only the small part of the strut to the ostium side branch. So we have to do the tap. But if we can get the distal strut at the ostium of the side branch, maybe we can do a professional T, or maybe just very little tap to going into the left main stent.
Okay.
And okay, this is just I think it's already explained by Dr. Hikichi. Yeah.
Everybody is waiting for your result.
Okay, thank you. First of all, I like to thank for all the panelists that give more insight of the left main bifurcation, and thanks from the EBC as well as the Japanese Bifurcation Club to give us some advice of this very interesting case. So during the 2 days, we have learned a lot. 2 cases of the left main stenting. There are similarities that the left main, left dominance, yesterday case is left dominance, Medina 1-1, not too calcified, although that's calcified. And what is a panel suggests, as simple as possible, and then keep it open. And then the difference between 2 cases is that we have a trifurcation, whatever, and then no stent at the left main. Lesion preparation we have to do. The purpose of lesion preparation is that all side branch should be keep it open. And I saw that 2 stent, two artery, LAD as well as circumflex, is really big artery. And the ostial of the both artery has a significant or critical stenosis. So in this scenario, I would like to do 2 stent strategy, which is decay crash, which is we are familiar with since 2013, I think, and 2012, with guidance of Professor Chen, of course. And you know that this is from the angiogram before. The right coronary artery is very small. And then see here that this is a trifurcation, as Professor Stankovic mentioned. And then we have already preparation of the lesion is very important with modification plaque, with cutting balloon or scoring balloon. And if we use scoring balloon, for example, in this case, I do with the smaller balloon first. Like this lesion, I do with the 2.5 scoring balloon at circumflex, and then scoring balloon 2.5, as you've seen before, at LED, left main LED. And then we use preparation LED, the bigger balloon, scoring balloon, 3.5, 15 millimeters. And from the, because the landing zone should be just the proximal of the diagonal second. And the length, according to IFS, is about 36 millimeters. And do with the 3.5 scoring balloon. And then, until the proximal with 4 millimeters, and then the left main 4 millimeters, and then LCX with balloon 3.5 millimeters. And what's happening after that? This is after preparation. You still see that the diagonal is still open. From the beginning, I don't want to touch the ramus because, even though that this is the trifurcation, what we did is actually, what we want to do is actually as simple as possible. If I can, of course, with one stent strategy is much better. But in this case, I don't believe that one stent strategy is better than two stent strategy, but I don't want to put the 3 stent strategy. So this is after a preparation of the 2 big artery. Then I put, this is a decay crush technique. So I put 4 18 millimeter of synergy now here. And then this is a balloon. This is balloon should be for the complete crush. This is 4 MC balloon 4 15. So complete crush here. Then after that, you can appreciate that the wiring here is crossing at the proximal part. Then after that, we open strap with 2.5 15 millimeter compliant balloon. Then we do the first kissing. Then we put, this is the first kissing. Then we put the second stent at the left main to LED. This is 38 millimeter 3.5. Consider that you have appropriate port length of balloon. If you, so to avoid of the mismatch, this is very, very important. So after that, then we open up. This is 3.5, 38 millimeters stent. I don't want to make edge dissection because this is even the landing zone is not very clear. So I very, very careful to inflate of the stent. Then I did a pot. This is a 5 millimeters balloon. NC5. I think it's a 12 millimeters balloon, 14 atmosphere. Then we do also pot the LED with 4 millimeters. So just proximal of the carina of the diagonal. And then you can see here the crossing of the second wire, not at the proximal, but mid of the strap. Of course, with the 3D OCT, it can be exactly to know where the wire crossing it. So then we open strap at circumflex with the 2.5. Then open up with 4 millimeters. Sorry, this is not 2.5, but 4 millimeters. Then there's a second kissing balloon with the NC balloon. In the beginning, from each by high pressure, about 12 millimeters, 12 atmosphere each. Then after that, simultaneous kissing balloon with the low pressure, about 8 atmosphere. And then finally, the report with NC balloon 5, 12, 14 atmosphere. If you have to remember that, I think as yesterday, Dr. Murasato mentioned regarding that, and Professor Guran also mentioned regarding trifurcation 0.577. But if you neglect it of the ramus, then you can calculate the diameter of the left main is 5.4 millimeters. So you have to choose which stent can be over expansion. So I choose the Abbott stent here that we can over expansion until 5.6 millimeters. This is the final result. Final result, I think so. Appreciate, I think acceptable final result. And you can see here that all brands, even Ramos is still open, and even you can see from here, it's still open, septal still open, and you can see here the diagonal still open. Then this is after LED IVUS post stenting, this diagonal, and it's the proximum of the diagonal second. Then you can see here that this is very nice, no edge dissection here. I think it's very nice. The position is quite good. And
you show me 2 layers.
Yeah, that's I think it's at this is for left main to LED.
Quite big vessel.
Yes, quite big vessel. And see here, that's no edge dissection. Even though not well expansion, but I think its position is very good.
You still see any thrombus?
No, it's not. I don't see any thrombus here. So post-op follow-up, the patient was discharged on the next day, no hematoma on the puncture side, and he has no symptom. You can take the stair up to 3rd floor. Medication is only aspirin, clopidogrel, rosuvastatin, azithromycin, 10 mg once a day, or once a day. On follow-up 1 month, he was well, no symptom, and the laboratory finding is NT-proBNP is normal, LDL 70, creatinine is 1.5. This is ECG is back to normal. So in conclusion, ladies and gentlemen, that in left main bifurcation, imaging is very important. I think we learn a lot from all panelists here, and preparation is also very important to keep side brain open. Port and report is also important, and availability of the length of port alone should be taken into account to avoid geographical mismatch. Make as simple as possible, even using 2-stent strategy. Thank you very much.
Of course, I knew that the result will be fantastic and impressive. Since yesterday, when Dr. Santoso commented the other left main case and he suggested DK crash, I knew that this will be for sure DK crash in such experienced hands. You will achieve image guiding fantastic result of the DK crash. That's the reason why I did not want to say what operator will do. I shared what is my personal perspective. So I'm agreeing with absolutely every step, except for maybe discussing 2 different ways, which branch should be the main vessel and which one should be crushed. Because of the plaque distribution, I may suggest the opposite, to crush first stent in the LAD and then have the main vessel circumflex because of the plaque compression, and maybe a larger vessel, the circ, better opening. And from my analysis of the plaque distribution, probably easier to compress the plaque, because most of the plaque was in the lateral wall extending from the left main into the circ. So the only diversity is which stent to crush. I believe LAD could be crushed as well first, and then circumflex taken as the main vessel. But I'm not very experienced with DK crush, so this is just my interpretation based on the plaque distribution. Otherwise, excellent case, I congratulate.
Also from my point of view, Muhammad, you have done perfect job. Really, congratulations. I fully agree with Garan. I also, if I could go with Dicky Crush, which was here good technical approach and suitable technique, I would also definitely go first, if I crush, then LAD, left main LAD stent will be crushed. And for me, similar like Garan suggested, for me the main line will be left main to the circ because of even larger 4.5 minimum diameter. So this will be for me the main stream. But finally you could manage this case perfectly, and you focus your attention to the main and side branch, which are huge in this case, and first diagonal and marginal branch were nicely open, and you could keep it simple and just keep it open and let it like you have done in this case. So from my point of view, really congratulations, tough case and perfect done.
I agree with both of you. I mean, that we can crush LED first. This is in my personal opinion that I can do like that, but most of my strategy of DK crush is that LED crush of the circumflex, the majority of the cases. And actually, both artery is the same caliber. It's about 4 millimeters, but I put 3.5 because I don't want make edge dissection at the mid of the LED, and we can see that it's really a good result with that's what my opinion.
Yeah, that's a good the technique and good result of the that's a complex case. I think in Japan very few cases we perform the crush or DK crush. Almost all cases maybe only emergency case. This case is one of the emergency. So I agree this result.
Thank you very much. I totally agree with Dr. Hikichi, but I in my daily practice I sometimes perform the crush technique for the high risk side branch occlusion cases. We have to protect the big side branch, the very compromised big side branches. So I like crush technique in such kind of the emergency case, or I think that the crush technique is one of the simple elective two-stent strategy. So the crush cure technique is the risk of the side branch or main branch compromise when after the crossover the stenting. So from I was finding there were the high risk finding of the occlusion. I prefer the crush technique. In my daily practice, I'm not so many experienced to perform the DK crush. So I learned a lot from the Dr. Munawar or other colleagues. So the very high pressure is needed for the DK crush. I learned much. Thank you very much. And a good result. Congratulations.
Okay.
Please.
Yeah, actually, that is, I have a question actually. The first is that Dr. Munawar has already calculated that the diameter of the LED is around 4.2, I think. But you decided to put the 3.5 stent. At which pressure you inflate? And is it correct that some experts said that the IFUS is tend to be slightly oversized, around 10%, the real diameter. Is it correct? This is the first question. And then the second regarding the Brilakis recommendation around the angle. Yeah, around the angle. What is your opinion? Maybe another expert opinion also regarding the Dr. Brilakis recommendation angle and the approach of the choice of the bifurcation stenting.
Thank you, Dr. Rifki. But I really, appreciate for your good question. The first is that if you look at the lesion, LAD, for example, it's really, most of them are diffuse disease. Some of that's free of the lesion, but the majority of the LAD is really, so we don't know where the landing zone. If you do like that, I think is what you can do is actually not really until the 4.2, for example, is I just a little bit lower. And the most important thing is that when you inflict the stent, I recommend to not to abrupt, increase the pressure. But I mean, this is just from lower pressure 2, and then 5 seconds, we have another 2 atmosphere and so forth. So with that kind, I think is we can at least avoid of the edge dissection. Then part, you're always doing every branch if possible. I mean, there's, if not, then the significant branch you have to make a part bigger with a bigger balloon, and finally at the left mid. That's number 2 is Brilak is say like that, but I mean that we have already discussed with Professor Chen, of course. In DK class, I think is like in definition 2. I think it's not really take into consideration regarding that. My experience is that with 90 degree like this, DK class is still very good.
Yeah. Absolutely. What I believe actually is the optimization of the result. If we can reach the target MSA, if we can do a good stent deployment, no malapposition, not much overlapping of the stent. So any technique, I believe, would give a pretty similar result. So I am not believer that one technique is better than the other, but what you can reach the optimal result, that's actually the target of the procedure. Thank you.
So I think, Professor Goram, do you have the last word of this case?
Yeah, there is one small technical detail that I would like to congratulate as well. After stenting the LAD, Dr. Munawar used 4.0 inside 3.5 up to the point of diagonal. So this was also pot for the diagonal vessel, just explaining how carefully he really performed step by step this intervention. So I'm sure my final word will be that I really had one of the most successful weekends from the teaching perspective for myself, because I learned a lot from all of you, and I really thank you very much for the kind invitation. This is really one of the best meetings that I attended this year. Thank you very much, and all the good wishes to colleagues.